Okay, so yeah, I mean, questions for tonight are fertility related. So any questions that you have wanted to ask about things like PCOS, male factor, recurrent implantation failure, recurrent miscarriages, endometriosis, pretty much anything which is fertility related, early pregnancy as well. We can kind of cover that tonight. So please just type up your questions and we'll try and go through them as much as we can. And yeah, just to reiterate what Maria said, is that we do offer this service for couples who are trying for a baby and kind of want to have a different approach to what a lot of IVF clinics are offering now, in terms of very personalized care, very intimate care, not something which is just kind of generic and standard. Then this is something that if you're interested in, you can look at our website, you can set up a free call with Maria, and you can take it from there.
Yeah. Dr. Sami, we do have a first question, and we have a lady who just joined us on the webinar. She is 37, her partner is 42, and she just would like to know if she should consider doing any genetic tests prior to conception, and maybe if you could explain as well what kind of genetic tests can be done.
Okay. So there's two different sets of genetic testing that can be done. One is testing on the prospective parents, so on the male and the female partner. And then you have also testing which can be done on an embryo following on from an IVF cycle. So testing on the partners will depend on family history. So when we meet initially with the patient and we take the history, we always ask about the family history, and if there are certain conditions which could be inherited, things like sickle cell, cystic fibrosis, thalassemia. These are probably more common than what people think. And if one partner has a gene, even though this is what we call a recessive, where you need two copies, then we always will get the other partner tested, because sometimes you might find, especially if the couple are both from similar ethnicity or maybe even reasonably related to each other, then there may be sharing of these genes, which can then mean that the child will have a 1 in 4 chance of having a disease. So screening for genetic causes is definitely linked to history. There are also some conditions which are dominant, so where one copy of the gene is enough. So if one partner has the gene, then there will be also a chance that the child can have the disease as well. And it will be 50% chance in that kind of situation. Now, there are other genetic tests which can be done, which are like screening tests, which are slightly getting a bit more popular nowadays, where there are companies that offer 250, 300 different autoimmune or genetic diseases that can be then picked up as recessive genes, because actually most of us will have some sort of recessive gene that could cause a disease if you end up with a partner who has a similar gene. So some couples are going for this. It's especially popular in the United States for some reason. It's very widely done even in IVF clinics. They quite often will recommend this to the patients, or patients themselves. They can just go online and order these tests and do them for each partner. And the idea is that they will check and see if they are matching for any diseases. And if they're matching for any diseases, then this could be an issue, because then they may have a 1 in 4 chance of having a child with that disease. And it may encourage them then to go through with IVF and to do the second type of genetic test, which is to screen the embryos. So screening of the embryos will involve doing an IVF cycle and getting eggs, getting sperm, making them into an embryo in the laboratory. And then to do the genetic test, we take the embryos to day 5 or day 6 or maximum day 7, what we call the blastocyst stage. And a biopsy will be done, which means we need to make a hole in the embryo with a laser, and we remove 5 to 8 cells from the embryo. Currently, we have to freeze the embryo because it takes about a couple of weeks to get the result. And then they can actually test for either the diseases, like we mentioned before, where they can look for sickle cell, thalassemia, see which of the embryos are carrying 1 copy, 2 copies, or no copies of the disease. And then the healthy embryos or carrier embryos can also be transferred, and the woman will get pregnant, hopefully, with an embryo which is not having this disease. And they can also check the number of chromosomes. And the number of chromosomes is important, because if the number of chromosomes is abnormal, then most likely this woman wouldn't get pregnant. The body will just reject normally these embryos most of the time. But sometimes you can get pregnant with such an embryo where the number of chromosomes are abnormal, and then most of those situations, the miscarriage will happen in the first few weeks, within the first 12 weeks typically of the pregnancy. It's rare, but sometimes when the number of chromosomes are abnormal, the pregnancy can continue, and then it's picked up on screening tests, which are typically done at 12 weeks most of the time. And you may have heard of things like Down syndrome, Edwards syndrome, Pateau syndrome, Turner syndrome. So these are all things that can be picked up on this kind of screening, in addition to many other number abnormalities as well, which don't have names like that.
Mm-hmm. Thank you so much, Dr. Sami, for such an open answer to this question. And it's very interesting to hear that there's so actually many options that patients can consider doing prior to conception. And we have a next question from the lady who very sadly had a miscarriage in June. And I'm really sorry to hear that. And it sounds really heartbreaking that it happened to be so, like very recently, and also that she didn't get enough of support. And the lady is just asking that there've been a lot of tests that she had, and everything looks fine, and still some reason why she didn't have her period yet coming. And from her question, it looks like there is no scarring detected. Probably she did have some scans done, and now she's wondering, so what can be done next, and if she should, so she's looking for the egg freezing. And it does sound that in this situation it's very important to get the right support, because it's never can be easy to go through the miscarriage. So Dr. Sami, if you could address this question.
Okay, yeah, I mean, again, I'm very sorry for this lady who experienced obviously a very traumatic thing, which is a miscarriage. And it's even more difficult, of course, if you don't have some support from family, from partners, etc. That makes it even harder. Now, you know, it's not correct that one of the partners can be blamed for this, of course. When a miscarriage happens, the first thing a woman thinks is, oh, is it my fault? Did I eat something wrong? Did I laugh too hard? Did I sneeze? Did I dance? Did I do this or that or whatever? And it's a very common scenario that people will look to kind of blame themselves for it. But in reality, the most common cause of miscarriage by far is the abnormality in chromosomes, just what we were mentioning before, where the number of chromosomes are not right. We call that aneuploidy. And if the embryo is genetically not made up right, then usually the pregnancy will fail within the first 12 weeks. And in a way, you know, it's not such a bad thing when that happens, because it's nature's way to prevent abnormal babies from being born. If the embryo wasn't made up genetically right, that was never going to be a healthy baby. And it's probably kinder that it ends this way rather than it gets picked up on screening tests later on, or, you know, the miscarriage happens much later, or there's some complication with the baby. So this isn't something that should be, you know, you should be taking blame for. And actually, miscarriages are very common. So in women who are even young women, even under 35, it's about 1 in 5 pregnancies, 20%, which will end in miscarriage, which is higher than what people think, because, you know, people don't talk about it nowadays. But if people are open and you start talking to people, you will find that there's a lot of miscarriage that just doesn't get mentioned or talked about. There's a little bit of a taboo for some reason. So it's more common than what people think. It's not something which is necessarily going to happen again. So if you've had one miscarriage, most likely, you know, at least if you're young, 80%, if you're a little bit older, 70% or 60%, you know, you will be likely to have a healthy baby next time, a successful pregnancy next time that you get pregnant. So, you know, it's not that if you have 1 or 2 miscarriages that this is necessarily meaning that you're never going to be able to succeed. And one should just stay positive, and it's quite often just bad luck more than anything else, especially when it's just a single miscarriage. Now, it is a little bit concerning that this lady's period hasn't come back since June, because it's not unusual that for 1 or 2 months after miscarriage, sometimes up to 3, the period can be delayed or a little bit messed up or irregular. That's kind of expected. But after 3 months, you would expect for a lady who has regular cycles, so if prior to the miscarriage the periods were coming regularly, then you would expect by 3 months that the periods should resume. So certainly, you know, it does need some investigating, and of course an ultrasound scan would be the first step. And the thing that of interest with the ultrasound scan is just check the lining of the uterus. Is it very thin? Is it thickening up? And also see if there's any activity on the ovaries, if there's any follicle growing. In addition to that, hormones should be checked to correlate with the scan to see, does it match what we would expect? You know, is there a high estrogen but a thin lining? Then even if you don't see scarring, because scarring is actually hard to see on ultrasound, it kind of suggests that if the estrogen is high and the lining is very thin, or if someone's taken a norepinephrine and they haven't bled following that, is it a lack of estrogen? Do you need to give estrogen first, then norepinephrine? Estrogen progesterone challenge, we call it. So there are a few things that need to happen really to check this. And if there is any suspicion of scarring, then the best way to check and possibly treat this scarring is the hysteroscopy, which is a telescope that goes inside the womb, and you can have direct vision that way. You can see exactly what's going on. It's not 2D grainy picture, black and white, like you get on ultrasound, even 3D ultrasound. This is actually direct vision. You see full 3D color, you know exactly what's in there, and you can see if there's any scarring without any issues really. And if there is scarring, then also hopefully that will be something that could be addressed and that could be cut away and hopefully resolved. But scarring isn't common if you haven't had a procedure to remove the pregnancy, an ERPC or DNC, whatever you want to call it. If you've not had a surgical procedure, or if you've not developed an infection following miscarriage, then it's actually very unlikely that you'll end up with scarring. So it could just be hormone imbalances, and therefore something that could be investigated and maybe even treated once you kind of get to the bottom of it.
Mm-hmm. And I just
now
would
for
like...
egg, I think just the last part of the question was egg freezing. So with egg freezing, this is an option. Mostly it's taken up by single women or women who are kind of not feeling that they're in a secure relationship and they want to preserve their fertility for the future. Now, I'm not sure how old this lady is, but you know, the ideal age for egg freezing is 35 and under. It can be done, you know, a little bit older than that as well, but that is the ideal age. Now at 34, this is you know a good age to do egg freezing. But if you feel that you are in a strong relationship, then embryo freezing is preferred. If you feel that you want to get pregnant straight away, I mean, hopefully this lady didn't have difficulty getting pregnant, then you know I don't think necessarily egg freezing is difficult as a problem for you, as a treatment, sorry, for you, because for people who are able to get pregnant themselves, then may not need egg freezing at this kind of age.
Mm-hmm. Thank you, Dr. Sami. Okay, and yes, and then the next question would be, the lady is asking to clarify, so if the embryo has been confirmed PGTA tested as a euploid embryo, so does embryo grading matter, and what would be the chances of failure if they would be high, and if there is no any other issues with female or male infertility? If you could address this, Dr. Sami, that would be great.
Okay, so with PGTA testing, it's just testing one aspect of the embryo, of course, which is the genetic makeup. It's not 100% accurate, but it's still pretty good. I'd say 97 to 98%, which I think is pretty good, but yes, it's not 100%. It's not testing everything else to do with the embryo. There are still other things which the embryo needs, and you know, is essential for the embryo to be able to implant and develop. So the other way that we assess embryos is to assess them under the microscope, or morphological assessment. And this is going to involve kind of looking at the structure of the embryo, number of cells, things like that, and therefore we can kind of make up this grade. Now, the grading system that we have currently, the morphological grading, it's very limited in what it tells you. So it doesn't necessarily tell us the better embryo, even though we say, okay, it's a better grade. Actually, it may not be a better embryo. It doesn't correlate with the genetic makeup. So sometimes we see the top grade embryos actually are genetically abnormal, and the lower grade embryos can be genetically healthy. And we see that even when we don't do genetic testing, even without the PGTA, sometimes we do put in the top grade embryos because we think that these are the better ones, and then it doesn't work, and then we don't do anything different, and we put in the lower grade, and this is the one that gives the baby. So it's limited in what it tells you. It's not the most essential thing, but it just gives us a guide, and it guides us as to whether or not it's worth testing this embryo, storing this embryo, transferring this embryo. Because if it's a very low grade, then it's probably not worth doing any of that. But apart from that information, I don't think it really tells us much more than this. So I think some people give it a lot more weight than it deserves. Now, if you do have a genetically tested embryo, and if you are given the right support during your frozen embryo transfer cycle, then you should have quite a good chance of getting pregnant and having a baby. I'd say 50 to 60% chance is usually what's quoted. But for someone with recurrent miscarriage, you also need to make sure that there's nothing else going on, because miscarriages, yes, the commonest cause is genetics, and a lot of the time doing genetic testing for people who have miscarriages due to genetic problems will solve the issue. But there are miscarriages that happen because of clotting issues. It could be because of not enough progesterone. It could be because of immune activity, which is affecting the embryo. It could be because of uterine factors. There are other things that can also lead to miscarriage or reduce the implantation potential, which need to be checked and addressed. So for anyone with recurrent miscarriage, they need to be kind of assessed properly for this, because a lot of these things that I just mentioned, they are treatable. And if you do that in combination with putting in a genetically healthy embryo, then hopefully the chances should be pretty high for it to succeed.
Thank you so much, Dr. Sami. And I think we have one more question. The lady is letting us know that she sadly had a miscarriage, and then it took 4 to 5 months to have her periods back. And then she did take vitamins and the supplements, and she's not really sure that actually did help with the hormones and hormonal imbalance. And then she's asking, she just wants to have some reassurance. And so like in regards of like what can be done next, and also the early miscarriage. So if you could early menopause, if you could just maybe, Dr. Sami, just to give some answers regarding the like reassurance, what to do in this situation.
So it's very unlikely to be early menopause for someone who just recently got pregnant 4 or 5 months ago. It's not likely you'll go from having pregnancy right straight to menopause. Menopause is a gradual change. You go through perimenopause first, which takes several years. And during perimenopause, it's difficult, not impossible, but difficult to get pregnant. And then you end up with menopause, which means cessation of periods for at least a year. It's not something which happens quickly. It's many years before that will actually occur. So I don't think this lady needs to be too worried about that. Now, yes, sometimes it does take a few months for the periods to come back. It's again just saying what I said before. If someone has had prior to the miscarriage regular periods, then this is the time that they need to start getting investigated. So they need to have some ultrasound scans, they need to have some hormone checks, and try and figure out why it is that the periods haven't come back. If it's just hormone imbalance, then again, that can be helped with some medication, and the woman can be given some medication to try and get her to ovulate and hopefully get pregnant. Or if there's something else going on, like perhaps scarring or something structural, then that needs to be addressed as well. But certainly, 4 or 5 months, if someone had regular periods before, I think this is the time to get checked and make sure that there isn't anything which needs treatment, really.
Mm-hmm. Thank you, Dr. Sami. And there is also a very interesting question. Dr. Sami, would you recommend PGTA testing for recurrent miscarriage when the last 2 miscarriages were tested and genetically normal?
No, is the short answer, because like I said before, miscarriages can happen for different reasons. And if you've had 2 miscarriages and if you're miscarrying healthy embryo, then that makes us really scratch our heads and think, okay, why is this lady miscarrying with a healthy embryo, an embryo that should be able to implant and develop? And then you need to have full investigation to find out what's going on here, to make sure that that issue is addressed and treated, because it doesn't seem likely PGTA is going to help anything. PGTA is only going to give you an embryo which is genetically normal to put back in. You may not even get pregnant with such an embryo. PGTA isn't guaranteed to give you a pregnancy even. And if you've miscarried healthy embryos before, then there's a high risk that you may miscarry a healthy embryo again unless the underlying cause is found and addressed. So no, I wouldn't recommend for this kind of situation PGTA. It can be useful for recurrent miscarriage, but not this kind of situation.
Thank you so much. And then we have another question. A lady has been trying so the question sounds that how long actually the couple should be trying before starting to worry and seeking the further help. And herself and her partner have been trying for over 1 year now, and they're using the ovulation test and actively trying in the ovulation window. And should they start to be worried, and should they do any tests to investigate why they haven't been able to conceive in the last year?
Okay, so the current recommendation is for any couple who's been trying actively for more than a year, they should be investigated if they are under the age of 40. If they're over the age of 40, then 6 months. After 6 months, they need to investigate. And if you're under 40 and you want to investigate after 6 months, then there's nothing wrong with that. But in general, we tend to recommend people try at least for a year before looking for tests and things if they're under the age of 40. So it depends definitely on the age. But yes, if you've been trying for a year and there's no pregnancy whatsoever, then some investigations need to happen. Basic investigations need to start with things like semen analysis for the man, because it's just one test for the man and you'll be able to figure out if there's anything wrong with him or not. And then for the woman, she'd have hormone tests, you'll have ultrasound scans, and maybe tubal checks sometimes, depending on the history. There may be other tests that could be recommended as well. But I would say, yes, after a year, you need to get some investigations done. You could try going through the GP or privately, whichever you prefer, although with the GPs, it is a bit more of a slower process, of course, through the NHS.
Thank you.
Also, just before I finish that answer, so with trying naturally, I usually don't recommend people to religiously rely on the ovulation sticks. The most important thing is to have frequent intercourse every 2 or 3 days, and I recommend people start from when the period finishes. So once you stop bleeding, you start having intercourse, not every day, but every 2 or 3 days. Every day isn't ideal for the sperm. And you keep going all the way until the next period comes, or hopefully it doesn't come because you're pregnant. That way, there will be sperm waiting for the egg, which is what you need. You have a short window with the egg. It's only about 24 to 36 hours max that the egg will survive, whereas sperm lasts 3 to 5 days in the female reproductive tract. And that is a better way than just relying on these sticks, because sometimes the sticks or the app or mucus or temperature or whatever you use to determine it may actually lead you astray. And it's common nowadays because of modern lifestyles, and people don't have the time or energy or to be having frequent intercourse. They kind of want to take the maybe easier option, or some people, they just really believe in these sticks, because I know it says 99% accurate on the box, but that's not really true. And they're having sex once a month, and then I've seen that many times in my clinic, and then when they come after a year and I say, oh, that's not the right way to do it, and they do it more frequently, I've seen many people get pregnant themselves. So yeah, you need to be having a frequent intercourse really, rather than just restricting yourself to the sticks. Now maybe they have been doing that, but I'm just wanted to mention that as well.
Thank you so much, Dr. Sami. And we have another question from the lady. If she had miscarried twice and genetic testing of the second pregnancy remains showed Turner and Battau's syndromes, should they consider genetic tests, and especially as two syndromes, or is this just something that can happen and nothing to do with the actual couple? And also, your partner's semen test has come back saying the morphology was only 1%, and is it so? And the second test due in January in 2024, and also can it be the reason for a miscarriage?
Okay. So Turner's is loss of one X chromosome, so it's a female, but she only has one X chromosome. Battau's is a trisomy, so it's 3 copies of, and so it's an extra copy of a chromosome, and it's what we call trisomy. So they're very different. They're not linked, and sometimes you can be unlucky twice. But also, I do not know the age of this lady, but as you get older, the chance of having chromosome abnormalities increases. And also, sometimes we see what complex abnormalities. So sometimes we see more than one abnormality for the same embryo. So it could be that you just get pregnant naturally yourself, and it could be fine, of course. Certainly, because if you had like 2 which were the same, so if you had 2 Battau's, then that would encourage us to say, okay, maybe one of you has what we call a balanced translocation, where one part of one chromosome is switched with another part of another chromosome, and then there's more likelihood of having this repeated, and certainly in that situation, then you would need to have the genetic screening. But in this kind of position, it's not essential. It may reduce the risk of miscarriage, yes, but doing the IVF with genetic screen is very difficult, very expensive process, and it's certainly not guaranteed to give you a pregnancy, and not guaranteed not to miscarry either. But with regards to the husband's sperm, if it's 1% morphology, that is definitely suboptimal. But correctly, you shouldn't rely just on one sample. So that's his first sample. If it's his first sample ever, then we should repeat it. Usually we give at least 2 months in between samples to see if it'll get any better. Sometimes the man may have suffered with a viral illness, or something which may have happened to him, or his lifestyle may not have been good for a while. And then just improving the lifestyle or giving some time, the sperm may normalize without doing anything at all. So it's important to recheck that. But if it does stay at 1%, it doesn't increase the miscarriage rate so much. More of an effect will be reducing the chance of getting pregnant naturally. And usually with 1% morphology, we would recommend doing IVF with ICSI to try and choose the sperm with the best shape to inject inside the egg. And that's going to improve the chance of pregnancy. But it's not that morphology is so much linked to miscarriage. It's more linked to actually not getting pregnant in the first place. So definitely wait for the retest, see what it's like. Hopefully it will be normal, it will be better. And the fact that they've had already 2 pregnancies naturally, I assume, would mean that hopefully they can still get pregnant again. But if it does stay like this, then IVF with ICSI is the next step.
Thank you so much. And the next question would be, so does actually eating organic really help to improve the egg quality? And if you also maybe can add what exactly can contribute to the better egg quality, what can be changed?
Okay, yeah, this is a good question. So unfortunately, there's no evidence to show that eating organic is going to improve egg quality. I'm not saying that it doesn't have any health benefits. That's not what I'm saying, but there's no concrete evidence that says that if you eat organic, then your egg quality is going to be better. You're going to have a better chance of getting pregnant. You're going to have a healthier pregnancy or any of that. So you don't necessarily need to feel bad about not eating organic, or if you eat organic, you shouldn't believe that this is going to fix your eggs or make them any better. Egg quality is something which is very much linked to the woman's age. So more than anything else, the age of the woman will impact it, because a woman is born with her eggs. She doesn't make new eggs. Even before you're born, you had your eggs inside your ovaries. And as you get older, the number will drop, yes. But also, as you get older, the quality will reduce. And mostly when we talk about quality of egg, the most important thing, the most relevant thing, is the thing that we've talked about a lot this evening, which is the genetic makeup, the chromosomes. And if the chromosomes are not right, then the embryo that's going to be created from this will be also abnormal and have the wrong number of chromosomes, and then much less likely to lead to pregnancy, much more likely to lead to a miscarriage. And if the genetics of the egg have been damaged as an aging effect, then this isn't something you can fix, not with diet, not with hormones, not with drugs. Unfortunately, this is a permanent change. It's still down to luck. I mean, still, as long as you're not 44 or over, you still should have some eggs which are genetically normal, genetically healthy, which will allow then for you to still have a chance of having a healthy pregnancy, healthy baby. But there are other things to do with egg quality, which may be then influenced by diet and supplements. Things like mitochondria, which are the energy factories for the egg. Other things may be influenced by diet and lifestyle, yes. But mostly it's age more than anything else. There are some more rare things which can affect the egg quality, things like women who have been exposed to chemotherapy, radiotherapy, or if women who have abused drugs as well, or too much alcohol or nicotine, things like this also are toxic and damaging to the egg quality. That can make things worse. Marijuana, is becoming more popular nowadays as well. So these are things which, of course, should be avoided. Healthy lifestyle is important. Healthy diet is important. But you don't have to eat organic, no.
Thank you so much. And also a very interesting question. When you do have a genetically normal and healthy embryo, what could be the reason of it not implanting and not resulting to a pregnancy?
So yes, most of the time when the implantation doesn't happen or miscarriage doesn't happen, it is an abnormal embryo. But we also know that when we transfer embryos which are tested and found to be genetically normal, they don't always result in a pregnancy. It's about 50 to 60% that will, but there's 40 or 50% that don't. So there's obviously something else going on, and there are other factors to do with the embryo which are important. You know, things like the metabolics of the embryo. Metabolomics is another field which embryologists are now investigating. Things like you know, just the general strength of the embryo as well. You know, things which we can't really measure yet. Hopefully, in the future, embryology will develop, and we'll be able to do more tests on embryo and have more understanding. But there are other things that can affect the embryo itself. And then, of course, not just the embryo is important for implantation, but the environment, the womb, the woman. You know, does she have autoimmune activity which can then attack the embryo and make it less likely to implant or less likely to develop if she is pregnant? Does she have clotting issues? Is there too much clotting which will affect the blood flow and the nutrition to the embryo? Is there a hormone deficiency in progesterone? Or is there a structural problem? There are other things to do with the environment which will also affect the chance of that embryo being able to implant and develop as well.
Thank you so much. And we have a very interesting question from a gentleman. So, is it possible for semen concentration to vary significantly? And himself and his wife, they've gone through 3 rounds of IVF, and the previous 5 samples were borderline, but all similar. And the latest test showed 60% decrease in concentration. From 9 milliliters to, from 9 millions to 3 millions per milliliter, and he is very worried about, and what could be done? How can we investigate these? And is it something reversible? And if you could advise on this, that would be great, Dr. Sami.
Okay. So, I mean, the reassuring thing for this man is that he's had 3 samples which were not too bad, which were borderline, or 5 samples, I think, actually. Which were not too bad. So this one, which has shown the decrease, is actually the odd one out. And like I mentioned earlier, sometimes there is something quite common. It's a viral infection. So any infection, especially if it causes a fever, whether it's COVID or flu, or even sometimes just, you know, a bad cold, sometimes it can depress the sperm for 2 or 3 months even. And then things pick up and go back to usual. And we see that quite a lot. So I wouldn't get too worked up about one sample being not so good. I mean, hopefully this is just a one-off thing, and hopefully things will improve for the next sample. But things that this man should be doing are making sure that he has the healthiest lifestyle possible. So, you know, healthy diet, not too much junk food or, you know, sugar, things like that. It's worth taking some supplements. So male fertility supplements are readily available over the counter now, and they can just patch up any holes in the diet. Frequent ejaculation is also good for the sperm. There's some myth that people try and save up for 10 days or 12 days and think the sperm is going to be better, but actually that's not the case. The ideal ejaculation frequency should be every 2 or 3 days, and that way you will get the best sperm, not every day, but every 2 or 3 days. Avoiding heat, so no hot bath, tight underwear, sauna, jacuzzi, long distance cycling, all of this is not good for the sperm either. So these are things that you should maintain, but if it's just a one-off, I wouldn't really panic about this. Hopefully the next time it will be better.
Thank you. And it's just like, is there any investigations that they should consider at this stage, and just considering the fact that they've had already 3 rounds of IVF treatment?
Well, this is another matter. So, I mean, if they've had IVF, you know, we need to look at what's happened with the IVF. You know, what have they had good fertilization rates? What the embryo's been looking like? How many embryos have they transferred? What other tests have been done? You know, to look at the environment. You know, because 3 cycles of IVF failing is a recurrent implantation failure. If they've had you know, no success whatsoever, then again, there should be some additional tests done on the woman, especially to check for things like clotting, things like immunes, things like checking her progesterone levels, maybe even microbiome checks. Things like this could be done to see if there are improvements that could be made in the environment to help for a future round.
Thank you so much. And the next question would be, the lady is 39 years old, and she has 2 embryos left. They're frozen after her fresh cycle, and unfortunately the fresh transfer did not work. And she just would like to ask your advice, what would be best in this situation, to put 1 or 2 embryos back within the same cycle. And she is just very worried that she might need another cycle to potentially freeze more embryos, or fresh cycle with a fresh transfer if the frozen embryo transfer will not work.
So if it's one cycle that's failed, then this is not a recurrent implantation failure. We don't need to necessarily panic. Sometimes, I mean, unfortunately, it doesn't always work with IVF. I wish it did, and sometimes you do have to try again. And it's good that she's got frozen embryos, because frozen embryos are easier, cheaper, safer than doing a whole new fresh cycle, if she's paying for it, of course. Now, the question about whether you put one or two embryos it's a big question, really. It depends on a lot of factors. On if, for example, some women, they have normal shaped uterus, it's a small uterus, you don't really want her to be having twin pregnancy, because we're not sure that this will continue for full term. Or women, sometimes they've had a lot of treatment to the cervix and they have a short cervix. Again, you don't really want this woman to have a high risk of having twins, because then this pregnancy may not end very well. So the whole history has to be taken into account. But for someone who doesn't have any of these issues and who's 39, it's reasonable to think about putting two embryos if the first cycle didn't succeed, as long as you feel confident that your clinic is going to look after everything else that's involved with going through another cycle. It's not a bad idea, because again, going back to the age factor at 39, unfortunately, quite a lot of the embryos are going to be genetically abnormal. We kind of expect around 65% of embryos at 39 to be genetically abnormal, and putting in two improves the odds of one of them being good in there. But of course, you have to counter that with the risk of having a multiple pregnancy, and twin pregnancy will increase the risk of pregnancy, not once, not double, but actually some of the risks of pregnancy increase quadruple, 4 times. So especially the risk that we worry about most with twins, one of the biggest risks is the multiple pregnancy can lead to preterm birth, and prematurity can have some quite bad consequences for the baby, or sometimes the baby doesn't make it if it's very preterm as well. So everything has to be kind of assessed, and if it's a private sector and then they're paying for it themselves, then sometimes also this is going to be involved in the decision, because they may not be able to afford to do 2 separate frozen cycles, but they could do one, and they want to have the best chance with this one. So there's a lot of factors that need to be discussed with your clinician, with your doctor, and the whole history has to be taken into account. So I would say that this is better to discuss it with your clinic, but it's not wrong in many situations to put in 2 embryos in this kind of position.
Thank you. And the next question would be, the lady is currently 41 and her husband is 42. They've never had conceived naturally, and she has adenomyosis, and the husband unfortunately has the low sperm count, and they are going through the first round of treatment now. It's probably going to be ICSI, and she's just wondering if you did see situations like hers, and what would be the live birth rate within her age group, and considering the situation as well.
Okay. So yes, I mean, first of all, because of the low sperm count, I would say again, ICSI is probably the way forwards here, and at this age, at 41. You don't want to be spending too much time waiting around before you start that, because it doesn't always work first time, and one may need to go for future cycles. So time is quite important here. Now, with regards to the adenomyosis, this is a spectrum. So sometimes adenomyosis is very mild, and I don't really believe that mild adenomyosis has too much impact on people getting pregnant. I see it very, very commonly in almost every day in my scanning clinic, and most of these women are able to get pregnant and don't have any issues. When it's very severe adenomyosis, that's a different matter. But still, even with severe adenomyosis, I've seen lots of people manage to get pregnant as long as they have enough care and support during the pregnancy. So I don't think that adenomyosis is a complete obstacle for someone to get pregnant. The lack of natural pregnancy for this couple sounds like more likely to be down to the sperm than anything else, although I'm not sure exactly how low the sperm count is, but when the sperm count is very low, then it does make it difficult. And it will be also a factor of egg quality because of her age. Now, live birth rates, success rates, of course, this does vary from clinic to clinic, as people should be aware. And in this country, the results of all clinics are in the UK are collected and displayed on the HFA website. So I would recommend for this lady to look at the HFA website, and she can see there and compare to her local clinics, or if she feels like she was prepared to travel further afield to go to a clinic with higher success rate, then that's what I would suggest, is to look at the HFA website and look for success rates, and you will find that for different age groups, for different situations, IVF, ICSI, it'll all be there for you to look at. It's not maybe the easiest website to navigate, I know, but if you spend a bit of time, you should be able to figure it out, hopefully.
Thank you so much. And we have another question. Lady is 41 and her husband is 38, and husband had reverse vasectomy in June, and they've been trying since, and they did address this issue and went to a fertility doctor, and the sperm analysis sounded like a good result, and all of the results from her side also good, and she is addressing the question that one of the tubes has some partial blockage potentially, and they both have very good and healthy lifestyle and taking supplements, and fertility doctor is advising to have IVF treatment, but they still would consider to try naturally and would leave IVF as a last option. And is there anything that we can recommend to them just to improve their chances, and maybe there is something that can be done that can result to the pregnancy within the shortest period of time without pursuing IVF treatment?
Okay. So vasectomy reversal is something which has reasonable success rate, and it's good that this couple's reversal was successful, and there was sperm which was found, which seems to be good. But one thing which is important when it comes to vasectomy reversal is that sometimes there are anti-sperm antibodies, especially if the reversal has happened after a long time from the vasectomy. First of all, I would say that they should check that when they've had the semen analysis, it's not been a very basic semen analysis. They need to have actually had someone look and check for antibodies, for the sperm antibodies, because if there are very high sperm antibodies, which is quite common actually with vasectomy reversal, then this will make it very hard for a natural conception. So if that's not been done, then I think that should be the next step, is to check for sperm antibodies first of all. Now, the other thing with vasectomy reversal is I've seen this unfortunately lots of times where it can be initially successful. So usually they ask the man to do a semen analysis within a couple of months from doing the reversal, but sadly after 4, 5, 6 months, a year sometimes, the reversal can fail, and the tube can get blocked again because of the formation of scar tissue and strictures. So I would say if it's once it's 6 months, I mean, June is not quite 6 months, but it's coming to it. Once it's 6 months, again, another semen test should be done just to make sure that things are still working well, because you don't want to be wasting time trying when there's actually no sperm there. So yeah, say first 2 things to check are the sperm antibodies and the sperm count as well. So another semen analysis probably should be done around about now, and that definitely is the first step in my opinion. Now, also unfortunately for this lady, there are a few things which are going against her. So one of her tubes is blocked, which means that when she ovulates, if she ovulates from the same side, I think it was the left side that was closed off, so if she ovulates from the left ovary, it's very unlikely she's going to get pregnant, and that kind of, it doesn't always, but in general cuts out about 50% of the cycles that she'll have, and there's no way to control making you ovulate from the right side instead of the left side. There's no drug that will specifically work in that way. You can't really control this. Some women do have an ovary which is more active than the other, so some women ovulate more from right rather than left, or vice versa, but for most women it does kind of end up as a shared role, and it's not necessarily like clockwork, but there'll be kind of fairly equal distribution between the 2 ovaries. So this is going to be a big factor as well, as her age, which will affect the egg quality, and also her AMH. 0.75 is a very low AMH, lower than average for her age. Now with AMH, sometimes this is something which can be just how she was born. So if she was born with low egg reserve, and if you test it again in 6 months or a year, it won't be terribly different. I mean, of course, it still will drop with age, but it won't be drastically different. But for some women, it does kind of hit a stage where the AMH or the egg reserve will drop very rapidly. And this is something which then may mean that she may have difficulty getting pregnant, even if she ends up doing IVF in the future. So there's not, again, anything you can do to fix the AMH. This is your egg reserve. You can't be getting more eggs, unfortunately. I know IVF for this lady does sound like, you know, she's not keen for doing it. She's not wanting it as the next option, but it certainly is sounding like the best option for her. You know, and I have to be honest, you know, I'm not someone who pushes IVF straight away. I do tend to see if we can exhaust other avenues first. But in this kind of scenario, with all the things adding up together, and the woman's age and the low egg reserve and the tube and you know, perhaps sperm antibodies as well, I think IVF maybe with ICSI would be the best chance for her to get pregnant, and something that she shouldn't postpone too long, because if you postpone it too long, the egg qualities and the number is not going to get any better, and it may be that it gets worse fairly quickly. And there's not really any other treatment option, you know, supplements that I can say which will fix the tube or the low egg reserve. There's nothing like that, I'm afraid. So it's up to her, of course. I mean, if they don't feel that they want to do IVF, that's their choice. But I'm not sure that there are other fertility treatments that I would suggest, really.
Thank you so much. And then just going back to the supplements, and the lady just asking, so if their quality is actually dependent on age, and having supplements and vitamins, how actually it can make a difference, and what would be, I would say, the percentage rate by taking supplements and not versus not taking supplements for age above 40, and if you could just give maybe a short comment about that regarding the supplements.
Yeah, so I still say that the age is the biggest factor, and the genetic makeup is something which cannot be fixed. But I did mention earlier that this is not the only thing which is reflecting egg quality. So there are other things like the mitochondria and other things to do with the ovarian function, which healthy diet and supplements can improve, can help with, and you know, things like CoQ10 and making sure that you have enough vitamin D, and just, you know, healthy diet in general, and avoiding things like too much alcohol, caffeine, cigarettes, anything which could be toxic to the eggs and make things worse, you should avoid. So yes, I still think that the egg quality mostly is determined by the age and the genetics, but this is something you can't change. You can't fix this. Unfortunately, you're not able to do anything about that. However, you can try and improve your lifestyle, your diet, and take some supplements. These are things that you can do and are good for your general health as well, not just for your fertility. So we do recommend these as well. You shouldn't just say, oh, you know, there's nothing I can do, and just give up on those as well.
Thank you. And a very interesting question, Dr. Sami, what actually can be done to improve the microbiome and the findings from the test? If you could explain, that would be great.
Okay. I mean, first of all, just the microbiome in general is the balance of healthy bacteria to abnormal bacteria. And it wasn't something that we looked at so much before for fertility and for reproductive medicine. For pregnancy, we didn't really focus on this so much. It was more, it started off with the gastrointestinal physicians who used to look at this, and you know, in relation to people having GI upsets, things like IBS and SIBO and all of these things, which have been studying the microbiome a lot. But recently we have, you know, some tests which have been developed, and there is more interest and more knowledge being gained to do the microbiome. We're not sure that we are actually having any effect to improve pregnancy rates as yet, or live birth rates as yet. But I think the evidence is building. I think this is definitely the future, and I think there is going to be a big role played by the microbiome in the coming few years. But in answer to the question, you know, what do you advise? I mean, first of all, diet is very important here. Healthy diet, lots of prebiotics and probiotics in the diet. So prebiotics, you know, things like lots of vegetable and fruit and things that the bacteria will want to digest. And then probiotics and things like yogurt and fermented food, kimchi, kefir. You know, you can look online. There's lots of foods which are containing probiotics, and you may also want to supplement with some probiotics as well, which can be in the form of oral probiotics, in the form of liquid supplements or capsules. And even nowadays we have vaginal probiotics, which can be used topically in the vagina to improve the distribution of bacteria and increase the lactobacillus, which is the healthy bacteria for the vagina, which you want lots of to try and suppress the bacteria that you don't really want growing, and the fungal growths as well. So if someone is concerned about microbiome, we tend to more worry about people with recurrent miscarriage or recurrent implantation failure. But you know, sometimes people just they want to do this test, and it's quite an easy test. And there are different tests which are out there. The one that I feel that I've become most comfortable using and happy using is the DAYE test, DAYE. It's an easy test. It's a tampon, which is not worn during the period, but outside of the period for 5 or 6 hours. It comes in a pack that you send the tampon back in the post, and you can just order this online yourself. And then the company will send a report with your analysis of the microbiome, and it will kind of give you a nice summary on a page on the front. And then if you have any issues, you can speak to your clinician and get advice about that. And if it's normal, then get some reassurance by it. But certainly in terms of improving the microbiome, I think diet is really key. Antibiotics is the thing which is disruptive to the microbiome, because when you take antibiotics, especially broad spectrum antibiotics, then it's kind of wiping out or nuking all the bacteria, including the good ones. And sometimes it takes a while to rebuild the microbiome. So for people who need antibiotics, which are very useful drugs and important drugs, then it may be worth taking probiotics in conjunction with that, just to try and make sure that the healthy bacteria can rebuild their colonies fairly quickly.
Thank you so much, Dr. Sami. And we have last question. The lady is asking, so is it actually worth to get ERA, Emma, and Alice tests done for implantation failure? And in what cases that would be recommended? And if actually the test can cause any complications itself? And maybe for listeners who we have here, if they don't know what is ERA-EMA analysis, if you could just give a very brief description on the test as well, that would be great. What exactly it does.
So these are the tests which are done by the company iGenomics, which is a Spanish company which are doing tests, and they very much promoted these tests about 9-10 years ago when they first came out as endometrio, which I think is a very clever marketing term, to be honest, so that you do them as a package. But they are different things. So the ERA test, which is the endometrial receptivity assay, is a test which will check for the implantation window, they call it, to see if the implantation window matches what you'd expect in terms of the amount of progesterone you've given for a frozen embryo replacement cycle. So this is all kind of IVF related. And if it doesn't match, then you may need to give an extra day of progesterone, or you may need to do the transfer a day earlier compared to what you would do normally. So this is the ERA. The EMA is checking the microbiome, and the ALICE is checking for chronic endometritis. And these tests are all done as a uterine biopsy, which means that a fairly firm plastic tube needs to go into the uterus, and they will scrape off some cells. Usually it's done in the luteal phase, so after the ovulation, which is not good for fertility patients, because if they're trying for pregnancy naturally, that will disrupt things. If they do happen to be pregnant naturally. And of course, because it's a biopsy, it's quite painful. It's not done under any anesthetic. I mean, you have a speculum like when you have your smear, but something actually goes inside the womb to scrape off some cells. And it's not always tolerated by women. It's not always easy to get the tube inside the uterus. So it's quite a fiddly and uncomfortable procedure. It doesn't really have many risks. I mean, I suppose because you are introducing something to the uterus, there's a very small risk of infection. But if it's done kind of aseptic conditions, then that should be very minimal risk. So I don't think there's much risk really from doing it. But it's something which came out as a test for recurrent IVF failure, recurrent implantation failure, not really recurrent miscarriage. Now, when it first came out, I remember very well, the company came to us and kind of promoted it very aggressively and said, we'll make it very easy for you. Here are the packs. We'll get the courier to come and pick it up. Here are the leaflets ready for your patients to look at. The cost is very encouraging. And we always are looking to do the new things and the best things, and something which is new and it sounds good in theory. We were quite excited to try. But what kind of felt after a while is that it wasn't really making much difference in terms of success rates, which is really the ultimate test. And with the ERAS test especially, I mean, I didn't really feel that we were getting anywhere with this. So quite a long time ago, probably about 6 years ago, maybe, I stopped doing it completely. And then the initial studies were all done and promoted by the iGenomics company, and they're all very favorable, which, you say, okay, there's some evidence that shows that it helps. But the more recent tests which have been done, the recent research this has been done, doesn't really encourage this, independent research. And there was a big study which was done last year from America, which involved several thousand cycles. It didn't really show any benefit from doing the ERA test specifically. The Emma and Alice, you could do the vaginal microbiome test, and it's going to be fairly similar. The vagina and the uterus, they're not closed off from each other. They are linked. Remember, the period comes out, the sperm goes in. They're not a sealed off system. So there is some reflection of the uterine microbiome from the vaginal microbiome as well. And instead of doing a very painful and uncomfortable test that needs to be done in a clinical scenario, this is something which is easy, and you can do it in the privacy of your home and just send it in the post, and it's it's much nicer to do. And I've completely moved away from doing MRIs to doing these types of tests now.
Thank you so much. No, that's such a great answer, and I hope everyone who listened us tonight got really reassured and their questions got answered. And I just would like to just add a few sentences. So if you do feel that you would like to speak to us, we're offering free consultations for 15 minutes. So please reach us out either through social media or through our website. And you also have ability to WhatsApp us. So we're always available, and then we can talk through at the comfort of your privacy and discuss all of your questions. And yes, so we have been recording this session, and we will share the link, so hopefully you can watch it again if if you would like to refer back. So thank you so much, and have a very good evening.